So what I'll do is, the order is handwriting with Nikki, Julie, and Jamie, and then music and cognition with Amelia. Is Sarah here? Okay, I didn't think that she was going to be here, but Madeline and Brianna, and then John will present. So we have 3. You all have 10 minutes, and I have a little 2-minute warning sign if you don't seem like you're going to be wrapping up anytime soon. But I think that most of you will do a good job of staying within the 10 minutes. So without further ado, we'll have Nikki, Julie, and Jamie. Are you able to share your screen, or do I need to give you that permission?
Let's see. I'm able to share my screen. You guys can see it clearly and everything and hear me?
Yes.
Okay, great. So unfortunately, me, Julie, and Jamie all just graduated this past Saturday. And so Julie and Jamie are both moving out and either moving or driving back home. So they weren't able to make it today. But my name is Nikki Latimer, and we did our project on the effects of auditory cues on variability and handwriting. So going ahead and just getting started, previous literature has shown that auditory cues have been found to reduce variability in fine motor tasks such as finger tapping. And different auditory cues have been shown to have effects on gross motor tasks as well, such as walking, for activating music and gait speed. And in a previous study, participants were asked to draw circles with a pacing tone at 1.25 hertz. And their writing showed participants had Parkinson's disease, and their handwriting showed lower variability in cycle time and amplitude, meaning that their handwriting was more consistent within their circles. So the American Parkinson's Disease Association suggests various pens, pencils, and writing devices are available to stabilize grip, and that weighted pens may help reduce tremors and improve handwriting for those with PD. However, there is limited research over weighted pens, and there is limited research examining the relationship between auditory cues such as music and handwriting. So for a purpose for the study, we aim to determine how auditory cues can affect this variability in fine motor tasks. And in our study, we specifically looked at handwriting. And we had 3 hypotheses. We hypothesized that the presence of auditory cues would decrease the amount of variability in handwriting compared to a condition with no auditory cues. We also hypothesized that letter height will increase, letter height will increase and muscle activity will improve during handwriting when using a weighted pen compared to a standard ballpoint pen. And we hypothesized that the use of a weighted pen would decrease variability in peak acceleration and movement time when compared to writing with just a standard ballpoint pen with auditory cues. So here are participant demographics. So we had 8 participants total with an average age of about 72. A little more than half were female at 62.5%. 100% were right-handed and 100% were Caucasian. The PD duration was about 8 years, and exactly half of our participants had their most affected side as their right side, which could explain some of our results as well, since 100% of them were right-handed and half of them had their most affected side as the right side. So for our experimental setup, participants use a standard ballpoint pen with an electromagnetic sensor attached at the tip of the pen, which you can see in this picture on the right. The electromagnetic position collecting sensor was placed directly in front of the paper. As you can see here, that's this box. And the software motion monitor was used to determine and measure electromagnetic sensory during our data collection. So for our experimental setup, to collect data on muscle activity, we used 2 electromyography sensors placed on the first dorsal interosseous, which is seen right here on the left, and also placed on the extensor digitorum communis muscle, which we can see is this long muscle here on the right. And we chose these muscles because they have been shown in previous studies to be activated during handwriting. So participants were asked to write continuous lowercase cursive L's on a 1.5 centimeter line paper as seen in this photo example on the bottom of the slide. And in order to emulate participants' natural handwriting, no instructions or example was given on the height or width that the letter needed to be. They were given unlimited practice trials until they felt comfortable with the task before each condition, and participants were randomly assigned the order of one of the four following conditions, and that was no music, metronome, activating music, and relaxing music. Participants completed 3 trials of each condition and had 10 seconds to complete each trial. And participants were also randomly assigned the order to complete all 4 conditions with either a standard ballpoint pen or a weighted pen with a grip. Each participant's self-pace was calculated during their first control trial and used in subsequent conditions, and the software pitch switch was used to accommodate each participant's self-pace handwriting. Self-pace was calculated by multiplying the amount of cursive L's written during that 10-second trial by 6 to get the L's per minute. And then this number was divided by 70 beats per minute for passive music and divided by 140 beats per minute to give the cadence for activating music. The participants began listening to a designated auditory cue 5 seconds before beginning their writing task, and they had 10 seconds to complete each trial. So for our outcome measures, we looked at the coefficient of variation, which allows us to see the consistency changes between conditions. The coefficient of variation is the standard deviation divided by the average. And so it kind of tells us the relative dispersion of data points in a data set around the mean, which can tell us variability between data series. So this was done, we took the average and the coefficient of variation for peak to peak distance of the L's. So that was the top of the L's to measure the distance, average and coefficient of variation for letter time, and average and coefficient of variation for peak to peak time. We also looked at the average and coefficient of variation for the area under the curve for the EDC muscle and the FDI muscle, but these will not be included in our results because they were found not significant. So for our results, first we have peak to peak distance, and we did find a significant difference between the weighted pen and the normal pen. We found that the weighted pen had greater variability, as seen here. The weighted pen is in red and the normal pen is in yellow, with the coefficient of variation on the y-axis. So we can visually see that the weighted pen was more variable than the normal pen, and this p-value was 0.018. And this was seen across all conditions. There is greater variability in the weighted pen compared to the normal pen. And we did not find any significance between conditions, only between the two pens. So next we have letter time, and we did find significance between just the pens again here, not between the conditions. And our p-value was 0.042. And so despite the visual appearance here, the weighted pen was found to be more variable compared to the normal pen for letter time coefficient of variation. So as we can see here, the red is slightly more variable compared to the normal pen, and that's what our statistics, but this p-value is a little bit weaker compared to our last p-value. And lastly, we have our peak to peak time. This is the average. And so in this condition, we found a significant difference between the activating condition right here and the control condition right here, saying that activating was significantly less time compared to the control. And this difference was seen in both pens, both the weighted and the standard ballpoint pen. Our p-value was 0.039, And we also found an interaction between our control and our metronome here, only with the standard ballpoint pen, which shows that the control was greater time than the metronome. And so we can kind of conclude from these results that the activating and the metronome conditions decrease time for handwriting. And this could be interpreted in different ways. It could mean that there is less difficulty to initiate muscle and letter movement, but it also could contribute to micrographia or smaller handwriting if they're writing too fast. So moving on to our discussion, we did find that auditory cues, specifically the metronome and the activating condition, had effects on time it takes to complete the series of letters. And this finding could be interpreted in different ways, as I mentioned in the previous slide. It could mean that there's less difficulty initiating movement, or it could be contributing to micrographia. We also found that the weighted pen tended to be more variable than the normal pen, which did not support our initial hypothesis. This was specifically for peak-to-peak distance and letter time. And this could have multiple explanations and could mean that there is a large learning effect since most of our participants, it was their first time using a weighted pen, or possibly it could mean that weighted pens may not be as affected as they are promoted. But the only way to answer this is just further research, especially since we did have a small sample size and we cannot include all of our original participants into our data analysis. But these trends do offer insight into further research. So our future directions, we are currently in the process of collecting survey responses as qualitative data to provide insight into practical applications of handwriting interventions in people with Parkinson's disease. And we are also currently writing our final research paper in hopes of publication for the Journal of Occupational Therapy this upcoming year. And then here are our citations. And are there any questions?
Thanks, Nikki. So we have about 3 minutes for questions, and then we can go to our next presenters. But great job. Thank you. It looks like we have a question from Keith asking, why was practice time allowed prior to data collection? Would no practice be more representative of real conditions?
I think that is a great question. I'm going to pull up the chat just so I can make sure to answer. Oh, I can't see it. So the reason that we had them practice beforehand was since it was their first time using a weighted pen, there could be like a learning effect. People are normally used to writing with a normal pen. So we wanted to make sure that they felt comfortable and didn't feel like they were just adjusting to the weighted pen the whole time. So that's why we allowed practice trials. We also allowed practice trials because, especially with the music conditions, they would hear the music and they would hear a tonal beep that would indicate to start, and then they would hear a beep to stop the 10 seconds of their trial. And because we counted the L's and everything, we really needed them to start and stop. So it was just those 10 seconds that we were measuring. And so that was another reason why we kind of did those practice trials so that we could make sure that they knew when to start and stop in the different conditions. But I do think it would be interesting to kind of look at the differences maybe in a weighted pen with no practice especially, and then even compare it to someone who has had experience or is familiar with the weighted pen and see if there is kind of that learning curve of like getting familiar with it. But that is something that could have impacted our results. And so, yeah, that's definitely a good question.
Any other questions? I have one if nobody else has any.
Yeah.
Can you give me an example of the music that you used for activating? I think you labeled it, and relaxing. What were the music choices for that?
Yes, and so this is kind of like another interesting part of our studying as well, is that could be interpreted in many different ways for many different people. Maybe our relaxing song didn't feel relaxing for the participant. And so that's definitely something that we're going to include in our paper. But both music pieces were from Dr. Stegemuller. So they were completely non-biased. They had never heard that piece before, and it was just a piano. And so the activating music had a higher cadence. It was a little bit more upbeat, as you can say, more activating, stimulating. And then the relaxing music was a lower cadence. So it was just a little bit slower and a little more like less variable in its tone changes and things. The activating really kind of changed a lot, and the relaxing pretty much stayed very consistent throughout the 10 seconds. So that's kind of how we define what the activating and relaxing music meant to us. But that definitely could have been interpreted differently from participants, which could also influence our results. But yeah.
Great, thank you so much. Any other questions for
Sure.
Nikki? Thanks for taking that on all by yourself. You did a great job.
Oh yeah, for sure.
Okay, so next we have Amelia and Madeline and Brianna. And I think that you have the ability to share your screen, whoever wants to share it.
Can you guys see my screen?
Yes, and are you all able to see me so I can give you a little 2-minute warning if needed?
Yeah, I can.
Okay, all right.
Okay, so our study was the effects of music training on fluid reasoning and cognitive inhibition in older adults with Parkinson's disease. I am Brianna Ackerman.
I'm Amelia Dixon.
And I'm Madeline Williams. And then Sarah was unable to be here, but she's part of our study as well.
Okay, so some terminology to start off about our study. Cognitive inhibition is stopping a mental process or ignoring irrelevant stimuli. And people with PD tend to have decreased cognitive inhibition. And then fluid reasoning is the adaptive thinking, problem solving, and abstract reasoning. And then fluid intelligence also decreases with age. So our research question was, do people with PD who have previous music training tend to perform better on tests, cognitive inhibition, and fluid reasoning? And then we had 2 objectives for our study. One is compare cognitive inhibition of musicians versus non-musicians with PD by using the Stroop test. And 2, compare fluid reasoning of musicians versus non-musicians with PD by using 2 tests from the kit of factor referenced cognitive test.
Okay, so for our inclusion and exclusion criteria, our inclusion criteria, you have to have an idiopathic diagnosis of PD and be on a stable anti-Parkinsonian medication for 30 plus days. Should be between the ages of 50 and 85 to kind of control for the age as a confounding variable, and have a high school diploma or higher, because we are looking at cognitive function, and cognitive function tends to be a little higher if you have more education. And then internet and Zoom access, since we're doing this online. For our exclusion criteria, we have the score of less than 24 on the mini mental state exam, and a score of greater than 20 on the Beck's depression inventory. And you'll be excluded if there's any blindness or significant vision impairment, because we are doing things that require visual interaction. So for our methodology, the participants will be asked questions about their past musical experiences. We use a music experience questionnaire that goes over your previous instrumental in music or singing musical experience, the amount of training you've had, what sort of groups you might have been involved with. And we have a quality of life survey called the PDQ 39 that assesses how often people with PD experience difficulty in different dimensions of daily living. To test for fluid reasoning, we're going to use 2 different tests from the kit of factor reference tests. The first one is the card rotations test, which you can see on the bottom left, where you have a figure and you have to mentally rotate it and see how many of the example figures it matches. So this will test spatial orientation, problem solving skills. And then on the right, you can see the paper folding test, where you have to mentally fold a piece of paper and punch a hole in it, and then unfold it mentally and try and see which of the examples it would match with. And this tests your mental visualization skills.
We are also going to be using the Stoop test, which the Stoop test assesses cognitive inhibition. Because of our study is going to be all online, we've created a PowerPoint that includes the Stoop test. The PowerPoint is going to be screen shared, and the participant will give verbal responses of the color of the blocks or the color of the words. And the score of the Stoop test is going to be based on accuracy. So the timing will not be recorded. And then we included 3 pictures of what the different trials of a Stoop test would be. So the left shows a neutral trial, which the participant would name the color of the block. The middle is what is called a congruent trial, and the participant will name the color of the word, but the color of the word will match what the color of the word ink is as well. And then on the right is the incongruent trial, which the color of the ink does not match the word, but the participant will respond with what the color of the ink is. And then past research showed that musical experience can improve various different functions. So improvements in verbal memory, verbal fluency, and planning functions. And there's been studies that also showed people with musical experience show better motor, auditory, and visuospatial functions. In many of these studies, they used participants that were healthy older adults. However, we hypothesize that musical experience will provide similar results within the participants in our study. So therefore, we expect to see older adults with PD who have musical experience will have more effective cognitive inhibition and fluid reasoning than those who don't. So looking at the broader impacts, our study is important because it will investigate the long-term musical training effects on cognitive inhibition and fluid reasoning in people with PD, which is an area of research that hasn't been researched that much. And we hope to investigate the hypothesis that long-term music involvement can help better maintain cognitive function in musicians of Parkinson's disease or with Parkinson's disease. And we also hope that the results of the study will highlight the importance of musical education. So looking at our next steps for our study, we're in the process of submitting for IRB approval. We're getting close, and then if we get approved for that, we'll start piloting and then hopefully be able to actually do it on participants. And then we just want to thank everyone involved in the neurophysiology lab, our graduate student mentor, Jesse Brown, and then Dr. Steckenmoller. And thanks to everyone for listening. Does anyone have any questions for us?
Thanks, everyone. Great job. And does anybody have any questions for our presenters? I have a question. How close are you to IRB submission?
I sent Dr. S all the information and the IRB, so I'm just waiting on approval from her.
Awesome. Very exciting. Any other questions?
Yes, I have one, Jesse.
Yeah, go ahead, Keith.
Does it matter whether someone hadn't done music for quite some time versus someone who's been doing music for a continual period of time prior to the proposed study? Is that a factor that's considered?
I think we're planning to just use the questionnaire to see what the musical experiences are. Obviously, there's going to be a lot of variability in people who have done it recently or did it a long time ago and for how long they did it. but I guess we'll take it into account and then use those results when we're looking at the final data to kind of get an idea of how to analyze it.
Great question. Any others? All right, then our third and final presenter is John. So
Thank you, Jesse.
you're welcome. Do you think you can, we have a little bit of extra time, so if you don't feel like you need to rush too much, I'll give you around 12 minutes. How about that?
Oh, all right. Appreciate that. Every minute is love. So let me go ahead and try to share my screen here. Oh, come on. Great way to spend the extra 2 minutes. Okay. So can everybody see my screen?
Yes.
Okay. So first of all, thank you, everybody. And I would like to present real quick the current status of my graduate project. I am a second-year master's student working with Dr. Stegemoller. And my project is about facilitating access to community support for people with Parkinson's through the co-design of mobile health technology. This is a creative component, so it will result in a design concept as opposed to research findings. So the focus is a little different. First of all, just a very quick, I'm doing this in the context of human-computer interaction. This is my current master's degree, and I intend to continue on this research in a subsequent PhD, which I will begin this coming fall. The idea is to improve accessibility for underrepresented populations in technology. Just a very quick shout out to the interviewing team. These are three more researchers that have been helping me out with interviews: Surya Smadi, Durga Sritharan, and Annalise Gubard. Really quickly, we're going to go over just like the current. Actually, I think this outline is a bit needs to change a little bit, but just to get started, we're just going to kind of dive a little bit deep into the implications that Parkinson's disease has for interacting with technology. We are all pretty familiar with the symptoms, but one thing to understand is that Parkinson's disease is often a very unique combination of symptoms. No two individuals have the same set of motor and non-motor symptoms. So it affects people in different ways and at a different rate of progression. So some of the implications for this is that it makes it difficult for people to seek out support in the community mainly, and participate in beneficial activities such as outreach groups, support groups, exercise therapy, and so on and so forth, due to either sedentarism, functional decline, embarrassment, or social isolation. Some of the currently available or most popular treatments for it is levodopa, dopamine agonists, and neurosurgical procedures such as deep brain stimulation. But the part that I want to focus on is adjuvant therapies or allied healthcare, focusing specifically on the non-clinical type of therapy that needs to be engaged with consistently over time and needs constant engagement. And that pretty much composed of dance therapy, music therapy, physical therapy, occupational speech therapy, and others alike. We're also looking at support groups, which have turned out to be very important in general to our participants. I'll talk a little bit about that a bit more. But then the whole array of these types of groups and programs that constitute the community's available response to Parkinson's disease needs. This is what this project is keeping in mind as the definition of community support. So we're looking at participation in group therapeutic activities that relate to physical exercise, music, dance, and sports, and others, with the objective of improving your own health and creating social connections. So uh, lastly, what we're looking at is basically how our technology is helping with this. The whole idea of accessing community support has become has become a lot more important, especially in the past year, since a lot of our daily activities have turned remote. So this area of opportunity pretty much emerged um, more organically. So just a very quick survey of recent technologies, but also technologies under development still that pretty much are helping address the different sides of Parkinson's disease. So there's currently things like smart bracelets to track episodes of bradykinesia, um, but also monitoring uh, L-DOPA effects over time. We also have, shoe-mounted sensors to track and monitor gait patterns, smart glasses using augmented reality to support activities of daily living, one of which can be navigational guidance. As we know, people with Parkinson's may be affected to several degrees in terms of visual spatial skills. Um, Microsoft Connect is another interesting one, that pretty much has been explored in terms of providing exercise therapy in gamified form. So basically, we're talking about games that help you go through exercise therapy. And lastly, we have smartphones, but broader sense, we have smart devices or mobile devices in a larger thing, like in a larger consideration of it, for mainly communications, managing symptoms, tracking medications, intake, of course, and accessing information, and lastly, connecting to community support. This is the area that we have decided to focus on for our project. This is the more ubiquitous technology of these ones right here, as well as other compatible devices such as tablets and computers or laptops. So, however, there are some limitations to these technologies, and it is that a lot of them are pretty much experimental, right? So they're not widely available. These are all developed in the context of applied research, and they show very promising results. But as far as I know, and as far as this project has surveyed, there are no currently widely available applications of these in the market. Smartphones provide like the quickest way and the quickest point of entry to provide these first sort of innovative solutions. So we're talking about mobile health, which is what I just said. This is basically you using smart devices to support continued health care. So we have a whole array of functionality here. But Parkinson's disease really affects interaction with technology. We have talked to some of our participants, and also it's been widely documented in research that motor symptoms as well as non-motor symptoms have several effects on how we can interact with technology. A few of these can count as bradykinesia, rigidity, and dyskinesias, which can make movements and basically touch screen interactions slower and more imprecise. But we also see hindered speech, which can be an issue if we want to give our device voice commands, which can be easier for some people and not that easy for other people. And but we also have the idea of information processing. So there needs to be a lot of consideration regarding how we view technology in such a small device. how we view information in such a small device, and how that can be affected by some common non-motor symptoms such as short-term memory loss or slowness of thought. So it is important to kind of scale these technologies up to larger screens, but also wearable devices, which can all be pretty compatible with each other. Tablets, laptops, computers can be considered in this in terms of a potential solution. So in summary, uh, I really didn't go into the definition of Parkinson's, but ultimately, like, there's the ideal cure, the ideal treatment, since there's no definitive cure, is a combination between medical and adjuvant treatments, such as continued engagement in therapies. Community support is beneficial for providing relief, as well as fulfilling social needs. Oops, I better hurry up. The limitations of current technologies are that they are pretty they're pretty experimental, and they're not compatible with each other on a wide scale, which makes it an opportunity to facilitate this idea of accessing community support more easily through already available devices. So this pretty much is our opportunity statement that I pretty much just described. So if we just kind of go real quickly on the methods that we have done so far, we have conducted a survey and conducted some interviews, which we are in the process of finishing in the next couple of weeks. This is done in the context of human-centered design. And right now we are at the point where we have converged into our solution space, and we'll talk about that in a little bit. So this is just like a recap of the methods that we have used. And but here it is. So from our survey results, we have come across the key components of community support as far as our participants as far as the participants go, have a lot to do with accessibility in terms of connecting through video conferencing, having support groups and groups which are local, and also backed up or supported by higher institutions such as universities or hospitals. Support groups to share experiences and information have been very much key. So these are all basically aspects that need to be kept in mind for the development of an application. And I'll show you guys, to wrap up, basically how this happens in this project, and the idea of the sense of partnership or fellowship that comes from being a part of any group in general. A few of these. This is just to show how many of our participants are engaged in support groups. Access mechanisms are word of mouth remains the key, like the main way in which people become aware of these. And so yeah, some people experience challenges accessing community support, and some of the reasons are basically have to do with the technical setup of remote access to community support. So this pretty much kind of leads us to, so sorry, I pretty much had to skip this one, but basically this talks about how common it is to participate with somebody in these groups. And so lastly, what we're doing is we're finishing interviewing people, people who have Parkinson's, caregivers and therapists as well, to get all of their perspectives and organize them into basically how they understand community support, how they access it, and what are the best, more successful strategies to do this. And basically all of the insights that we have gathered from surveys and interviews are meant to inform design criteria. So like things like connecting through Zoom means that an ideal solution should have the functionality of enabling video chat. Local offering means that it should locate groups in the near vicinity, and so on and so forth. I cannot go through all of the design criteria, but this is how they're adding up into what ultimately, if we add all of these criteria together, we're going to come up with potential solutions. And this is where all of you would come in. What is coming up in this project is co-creation, co-design sessions where people who have Parkinson's, but also caregivers and therapists, people who are involved with the delivery of care, we're going to come together and produce some interesting ideas. So that's pretty much is the main next step. But that pretty much consists of us, going over the design criteria and basically brainstorming ideas together. So this is currently the status of the project. I'm sorry I ran a little bit long, but I don't know if we would have time for questions. This is the project roadmap, but this is essentially what I've been talking about. This is what we're going to be going over, and finally, I believe that pretty much wraps it up.
That was a lot to cover in a little bit of time. But Keith does have a question
Of course.
in the chat, and we're good until we see the little message pop up to join the bigger group. So we have time for questions. Keith asks, are you familiar with the Empower 2 study that is tracking motor control, finger tapping, gait, and tremor using smartphones? Do you know what they have found, and would it be useful for patients to track their own abilities and potential decline?
I don't think I have heard about this particular project. I do think that keeping track of the symptoms can be useful, particularly particularly when we look at effects of alternative treatments, or if we want to keep a documented record of pretty much symptom progression or severity. I do know that in terms of the scope of the project, it could be useful to assess like some sort of like group matching. Depending on how severe your symptoms are, you may be more like you may be able to benefit more from, for example, occupational therapy. If your problems have to do a lot more with fine motor skills or things like that. So it could inform some sort of user group matching that can definitely be a part of the functionality of a potential solution. I don't know if that pretty much answered the question. I have not heard about this specific one. This is just what came to mind when you mentioned it.
Anybody else have any questions for John? Okay, well, we've been instructed to chat among ourselves until we see the little sign to join the rest of the group. I know the third group had 4 presentations to do, so maybe they're running a little bit long too. So yes, so I'm going to stop recording.